You know, you can go to Credit Valley and have your EVAR. You can go to Credit Valley and have a very good infrainguinal bypass. You can go to Credit Valley, you have renal bypasses. And you can go to Sunnybrook and have other operations. You can go, no, the question is, what makes us a center of excellence? And this is an example. This is the test for you, for us, for me, to know if we are the center of excellence, if you're able to make these people survive. Now, having said that, what is that this mean? This means that when you will see a patient in intensive care like these people, you will have to contribute to A, support the patient, B, support the family, and C, don't get discouraged. And if I say that, means there is a reason. You will get discouraged, because I do get discouraged. You go there, and you see the patient is sick, he's still intubated 3 weeks later, it looks as if he's in coma, but little by little, they do survive. And why do they survive? Or they should survive for two reasons. A, technically is an operation that can be done. We are a long way away from 1983, when I did my first thoracoabdominal at Harvard. We did the 3 in 1 year, 100% mortality. All 3 died. And we were in a center of excellence. But issue is, at that time, techniques were not very evolved. Today we have the technique. So that aspect, no, it should be taken care of. And the technique is there, and we have the experience to do these operations. So at this point, I want to take a little pause, A, because otherwise I feel like a priest, and B, because I get tired, and C, because I want to hear some of your questions. Yes?
What quality of life do you have after this type of surgery? Like, is there any paralysis?
Excellent question. We'll start with the easy answer to that first, because that's something that I've looked into. What is the survival? That is the length. If you survive the operation, you leave the hospital, do they die a month later? Do they die 6 months later? And their survival, if they leave the hospital, is similar to the matched population. So that means they do survive well. Now, with respect to quality of life, nobody has looked into it in details. I'm in the process of publishing actually a paper on pilot project on quality of life of these people. And we are already almost at the end of the paper. I have one resident who is, actually one medical student who is in London. The resident was my stretches at the Cleveland Clinic, so it's very difficult to finalize, but it's almost there. And basically what we have noticed, using 2 qualities of life, one is the Karnofsky scale, that probably you all know because it's a musculoskeletal type of scale, and it's very simple, very used in hospitals. And the other one is the illness intrusiveness rating scale, which is another scale looking at 11 domains of quality of life, that these people actually have a bad quality of life before they go in. And we're not sure exactly why, mostly because the sample that I have is not so big to do exploratory analysis, so it's still a small group. But we postulated that one of the aspects is the anxiety about it. So even before you do anything, their quality of life is not good because they have this disease which contributes to their fear. Some of which is fostered by us, physicians and healthcare practitioners. My philosophy when I see one of these patients is to try to make them feel well and demystify the disease with respect to the immediate risk. I do not demystify the disease, and already some of you have been of witness my style in communicating what the disease is. I don't underestimate it. But when a patient comes to my office, basically, just to make it short, I could condensate this discussion. I tell them, you know what? You have a problem. It's a big problem. Don't worry about it. Let me worry. You leave the office, enjoy life until I'm going to do your surgery. I don't tell them, don't lift, don't open the window, you catch a draft of wind, don't use the lawnmower, don't breathe, because A, nobody has ever proved that if you stay perfectly still, your aneurysm is not going to burst. B, nobody has ever proved if you do full activity, your aneurysm is going to burst. So once we tell them, these people, don't lift 5 pounds, don't do this, don't do that, what kind of quality of life they have? A miserable quality of life. It's what I call terroristic medicine. So these people have a bad quality of life before. After surgery, their quality of life is basically unchanged. Now, some of the anxiety is gone, but maybe it's replaced by aches and pains in the thoracotomy, that they feel weak for a long period of time. So the quality of life is not great when we look at all of them. If you look at MARFA, that is the subgroup of people under 55, their quality of life is excellent. So it becomes basically undistinguishable than a normal person. And the reason being that they are young people. So I have people who went to chop wood, to play tennis, but they are young people that are often, professional. They are committed to get better. The people who have a miserable quality of life are those who become paraplegic. Because basically the quality of life changed dramatically from a regular existence of bipedal function, normal bowel function, normal urine function, to a paraplegic on a wheelchair with dysfunction of bowel, dysfunction of urine, and so on. So in that particular subgroup is 100% worse. And the other people with altered quality of life is those who go on dialysis, because 3 times a week they have to go on dialysis. So the entire effort of this operation is A, survival, B, prevention of paraplegia, and C, prevention of dialysis. Before I continue, did that answer your question?
It has, but I have another part to that question. How do you prevent paralysis and prevent them from going on dialysis long term?
That's very good. That's right. Survival, we said the prevention is based on us, you and I. How do we prevent paralysis? Well, prevention of paralysis, I should anticipate. Basically, if I look at all 300 patients I had, the overall, any neurologic deficit, any, means from wheelchair bound to capable to walk with a walker or with a cane, is 7.9%. So we call paraparesis paraplegia. So all neurologic deficit from mild to severe was 7.9%. This covers a span of 18 years. Okay? If I look at my last 3 years, we had a 0 paraplegia. We have done 60 cases in the last 3 years. 0 paraplegia. What has changed? I got better. In the last 3 years, and I hope that this is what we'll be able to reproduce, so I will call the contemporary experience. What has changed is something related to techniques and something related to the hospital. So I'll give you the experience I had in the last 3 years. With respect to techniques, that was easy. You remember the drawing that I've done? We do a technique called the multiple sequential, and I will show you this. It will be clearer to you when I'll show it to you. We do a multiple sequential replacement of the aorta. And during the different stages, the aorta is perfused in one way or another one through a circuit which I have designed. So at any point in time, there is always perfusion. So that's the perfusion aspect. The second is we have shown that CSF drainage reduces the incidence of paraplegia. And you may find in Journal of Vascular Surgery a systematic review which I've published a couple of years ago. And the third is that we reattach the intercostal arteries very aggressively. In fact, I'm the only one that I know existing in the world that reattach the intercostal artery with a compulsiveness that I can sort of see my resident fellows and assistant fade away after my 16th anastomosis. And you will see this aorta look like a big worm with many worms coming out. Each of those worms are bypasses to the intercostal arteries. So reattach intercostal arteries aggressively. Finally, and this is again, is not on paper simply because we are too kind on residents in this country. I can tell it's different in Europe. But anyway, about 3 years ago, we did a double blind with a blinded control animal study where we took 60 medium-sized pigs. That means a lot of prosciuttos and a lot of money because they had to be virus-free. So 60 virus-free medium-sized pigs, they cost us $25,000. And what we did, we had a sham group, a sham with control, and then we had the intervention and the control. And we had a model that could reproduce paraplegia in these pigs. And we treated the treatment group with acetylcysteine. Now, acetylcysteine actually, we were using because we were interested in the kidneys. Because, about a few years ago, there was a big hype about acetylcysteine as a kidney protector and so on. So, we were doing this model to make ischemia to the kidney. We were causing paraplegia. Incidentally, we discovered, that was in the first few, that those who were receiving this very high dose of acetylcysteine, we were giving 150 milligrams per kilo, they were not becoming paraplegic. So that was the pilot, I remember. Then we applied to PSI, then we did the full 60 pigs. And again, we confirmed that. We had the independent neurology assessing the pig and so on, and it seems to be a real effect. Has been presented at many meetings and is not published simply because the resident is holding all the data, is not giving them up. So, in fact, I wrote an email this weekend to him reminding him, just don't worry about it. I'll put your first name, just give me the darn thing and I'll write it. So, acetylcysteine also has been another intervention that we added to the prevention of paraplegia. There's one fourth element, and that's in intensive care. In intensive care, see, we are a society of no pain. If you ask me, do you have pain? And I had a cat, like right now, if you ask me, do you have pain? I would say yes, I have a headache. Are you going to give me any morphine? Are you going to give me any oxycodone? You're not. But as soon as the patient gets surgery and he winks a little, he's in pain. Let's give him morphine, let's give him something. This has a major repercussion in this type of patients because you cannot assess them properly. And if you cannot assess them properly, you cannot detect early paraplegia. And delayed paraplegia, either early or delayed, but particularly insidious is delayed paraplegia. which can occur as long as 8 days after the operation. But the one patient I had with the latest paraplegia was 8 days after surgery, and it can occur 2 days after surgery. If you can assess the neurologic status on an hourly basis and reliably, if the patient loses neurologic function, you can intervene. You can insert a CSF drainage if it has been pulled out. You can increase the arterial pressure if he's hypotensive, and even if he's not hypotensive. You can give acetylcysteine. So there are all interventions which can reverse the paraplegia. And in my database, I have at least 6 patients in whom a neurologic deficit occurred which was reversible through these interventions. So the fourth element I was talking about is aggressive postoperative care aiming at neurologic assessment and control of blood pressure. I had a standard order that everybody frowned upon on me because, we have to be safe. That the nurse in ICU can initiate inotropes without a doctor's order. Because indeed, if the patient is becoming paraplegic and is hypotensive, the easiest thing to do is, if you have an inotrope, just to clip the thing and increase the blood pressure, and then call the doc.
Okay. All right.
Unfortunately, this didn't go through. So what we are left is, because you can do it, if you see something like that, open all your IV, give fluid, call the resident and tell them, because the resident may have 1 or 2, maybe doesn't know about it at all. Tell them, this guy needs the inotrope. The resident says yes, then you can start. So all these, see how many things we have to talk to prevent paraplegia, because it's a multimodality approach to prevention of paraplegia. With respect to kidneys, it's somewhat easier. Kidneys, contrary-wise to what we think, they are very resistant. If we provide nutrition to the patient, we tend to forget that the cells of the nephrons have a very high metabolism. In fact, if you look under the microscope, you see all these mitochondria in the proximal tubule, like hundreds of mitochondria, because they have to do a lot of work. And like every person that works very hard, it needs a lot of food. So one of the things is nutrition. And the second thing is, when they are ischemic, to cool them down. One friend of mine, Dr. Safi, who was also one of my mentors, said, it's very simple, Claudio. Cold meat in the refrigerator doesn't smell. So you cool them. And basically, you were at the talk this afternoon. Yes, you need somebody? Okay. You were at the meeting. In essence, we cool the kidney. And we cool the kidney in 2 ways. If it's a group 4, that is, I'm not using extracorporeal circulation, I actually inject the kidney with a chilled solution containing plasma-like, dexamethasone, mannitol, and heparin. This cocktail is, I don't know if it works or not, but it's cold for sure, and will kill the kidney, will chill the kidney. I have a temperature probe. I drop the temperature below 15 degrees centigrades during the ischemia time. The cocktail is because dexamethasone hopefully stabilizes the membrane as a glucocorticosteroid.